So we proceed with our next session. I would like to welcome the chairpersons of this session. So Professor Niranjan Khandelwal sir will continue as the chairperson for this session also. I would also like to invite Dr. Bhavna Sonavane, who is the professor and head of the Department of Radiodiagnosis, IGGMC Nagpur, to kindly be a chairperson for this session. And Dr. Udaybhan Singh, who is the director and consultant of Lobun Star Diagnostic and Interventional Center. And after this, so I would like to request all the speakers to kindly limit to 10 to 15 minutes so that we can finish the sessions in time. Thank you so much. Over to Khandelwal sir.
Is the stereotactic one, and Dr. Palak. Yeah, Dr. Palak and Dr. Someshri will take up, and Aman Daptari will be moderating this session. She's been assisted with her student here from the Tata Memorial. Where is he? And of course, Aman is a consultant breast radiologist in the Hinduja Hospital. Yes, Aman, go ahead.
Hi, good morning, everyone. So we're going to show you a video of stereotactic VAB, but before that, we'll just go through a few points. So just for people who don't know what is a stereotactic biopsy, so just give you a few pointers, and then we'll show the video, and then we'll take questions. Sounds good? So when you say stereotactic biopsy, what do you mean by a stereotactic biopsy? A stereotactic biopsy is done with mammo guidance, and in a mammo film, it's a 2D imaging. But when we do a biopsy, we need to know 3 coordinates. You need to know the X, Y, and the Z. So we actually take 2 planar views to get on a projection to get the Z, or the depth of the lesion. So this is what stereotactic is, where we take an image. So we take a scout view to just see the lesion. Once you see the lesion, you take 2 views, one at -15 and one at +15. When you have 2 images and you can mark your lesion on both the images, the computer computes the Z-axis, which is the depth of the lesion, which is what you need to know when you do a biopsy. So with the principle of stereotacty, we can do a stereotactic guided biopsy where you know the X, Y, and Z of the lesion. When you do a stereotactic biopsy, we generally do it for anything that is not seen on ultrasound, because if ultrasound is available and the lesion is seen well on ultrasound, it's the easiest biopsy to do. And ultrasound guided core needle biopsy is the easiest for the patient, radiologist, and cost-wise. So that's the biopsy of choice. But there are certain calcifications, sometimes a focal asymmetry, sometimes architectural distortion that does not have an ultrasound correlate. So when that happens, we use the help of mammography and do a stereotactic or a stereotactic vacuum-assisted biopsy. We generally avoid stereotactic core needle biopsies because you very often have undersampling. So if you do have a VAB unit available, you always do a stereotactic VAB biopsy to get better sampling and less underestimation. You can have 2 systems, a prone and upright. In India, most centers have an upright system. So basically, you have a stereotactic attachment that you can put on your mammography machine. You have to buy that separately, but you can buy that attachment as an addition to what your mammography machine has. This is what the upright system looks like. This is just to show you what a prone system looks like, which is a separate unit. It's completely a separate unit from your mammography machine. We have 2 main VAB needles in the country. One is the ATEC Hologic machine, which is on the left, which comes with the Hologic machine, and the other is the BARD. Those of you who did the workshop yesterday, the BARD needles is the one we use, and that's more widely available. So most important thing of doing this procedure is knowing what to biopsy. The procedure itself is pretty simple. The computer gives you coordinates, you put the needle in, but you need to know what to target. And because of that, and especially in our country, because often the patient has been worked up in a different hospital and has come to you for the procedure, you need to look at the films very well, know exactly what you're going to target, and it's better to do that a day before. So you can look at your CC view. If they've not taken a lateral view and they only have an oblique view, take the lateral view, make sure you're seeing the lesion you need to biopsy well. You can talk to the patient, explaining the procedure so the patient knows what to expect, and also the cost, because it's a significant cost to the patient to do this procedure. On the day of the procedure, make sure the system calibration or QA is done for the procedure before you get the patient in. You need to take, as was talked before, written informed consent, which is very important because the patient is going to be in compression throughout this procedure. So you have to tell the patient that she is going to be in compression. It's very important for her not to move. If she does not know that and you've just put her in compression for 10 minutes, she's going to wonder what you're doing. So very important to explain to her each step of the procedure. If you're going to use a clip, which we often use when we do a VAB for microcalcifications, you need to tell her you're going to be putting a marker or a clip inside. There are some patients who do not want any foreign body in them, and you have to respect their decision in the end. And make sure you have everything you need in the biopsy room before you start. Before you put the patient in compression, make sure you have the right needles. If you're going to use a marker, make sure you have the marker, not expired, and you're not sending someone outside to get something from another room. Because the patient is in compression, you need to be really quick, you need to be fast, so that you keep the patient in compression the least time. You look at your CC and lateral views, and this is probably the most important thing. How do you approach a patient? So you want to approach the lesion by the shortest distance available. You can compress the breast in a CC view and either go superiorly, and in some machines like the Prone, you can go inferiorly as well. Or you compress the patient in an ML position and you can go laterally or medially. So you look at the CC and lateral views and you try to figure out which is the shortest distance. So this was a group of calcifications, just showing it was a new group of calcifications. And okay, so this is the CC. So this is the lateral aspect of the breast. This is the medial aspect of the breast. And this is a lateral view where this is the superior aspect of the breast, and it's the inferior aspect of the breast. So the shortest distance is the lateral distance. So I want the needle in the breast laterally. If I want to do that, I will put the patient in an LM position where the paddle is open laterally. So my needle is going laterally, so it's going in the breast for a very short distance. So your direction is very important, and these are things you have to examine or try and figure out before you take the patient, so you know which projection you have to put the patient in. Okay? So once we've decided all that, we'll take the patient in, we've explained the patient the procedure, and we take her to the room, and then we can start and then Palak will carry on about how the actual procedure is done.
Can you please play the video? Yes, thank you so much, Dr. Raman. She's covered a lot of points, and all of them are so very relevant when we take the patient for the procedure. And one thing, until that begins, we sometimes ask the patients for a music of their choice, and we try to play that, if not to try to have some instrumental music. And sometimes if it is not played, whatever, but definitely when the blood pressure is high and not settling down, we definitely try to add these few additional components, and it does alleviate the anxiety, and it helps for a better procedure. Yeah, so this is a lesion in the CC and the MLO view. I cannot blame you if you cannot see the microcalcifications, because I cannot from here. Can we go to the next image? Yeah, and that is why we have magnified images. So we can see the group of microcalcifications over here, and they are not the classic BI-RADS 5 types, and they are not the BI-RADS 3 either. They are a BI-RADS 4, and all of them are fairly representative of each other. So when you have multiple groups, we triage which is the worst looking one, and if not, then we can choose one among the others. So representativeness of the microcalcification needs to be looked into. Could you play the video, please? So we were planning to show a live relay of all the cases, but then there were some administrative and
So we are compressing in the CCV. We have adequate thickness of the breast after compression, measuring around 4.5 centimeter. So this is the first projection that is taken in the failure caudal view. Since the left breast is being targeted, the image is a replica of the way it is placed on the CC on the table, and the outer aspect is on the left by convention, the way it is for the patient, and here it is on the inner side. So we are targeting the calcifications on the outer side. Next, please.
So this is important because the CC
So after this,
view
we
is
take
not what it
stereotactic
always
paired
is when
views
we do
in the plus and
biopsy.
minus
We are
15-degree
always used to
angulation.
a CC view being on the outer side and the inner approach on the medial side. But when we are taking
So
a
this is
patient
a
on
minus
table,
15-degree
the
view,
outer and the
and
inner
the
curvatures
projection
are
is
the way
seen,
the
and then we
patient
take a
is on
plus
table,
15-degree
so
view.
it can be a flip of the image. This needs to be remembered.
We choose a measurement, the targeting icon. It has to be focused on a group of microcalcifications that we want to target. So now we have to target, we will choose a group of microcalcifications. The group is much more grouped up in this particular location. So I think we can choose this. If we choose this group of calcifications, we will be going to a much deeper location within the breast, and we would rather prefer to go superficial to this location. So we will look for another group of microcalcifications. So now placing a cursor over here, selecting this group of microcalcifications makes us go deeper only by around 1.5 centimeters. So this is not safer. So we will choose this group of microcalcifications. Now, because all the microcalcifications are not giving a good access, because the one that we chose is showing a collision risk posteriorly. So we will try to include greater part of the breast away from the chest wall. And there are some microcalcifications also on the lateral aspect. So we will try to find another group of appropriate microcalcification.
So rolling and maneuvering of the breast during a procedure can really make the inaccessible microcalcifications accessible significantly. So we must try with alternate rotations and rolling of the breast.
So this is a 0-degree axis. Minus 15-degree angulation. Followed by plus 15-degree angulation.
The elbow ridge. 52.
So we have taken another paired view. Now this particular group of microcalcifications, we see which of them is matching with each other, and it has to correlate with the microcalcifications in the 0-degree view as such. So this gives us a depth of 3 centimeters, which means it is closer to the skin, nearly in the midway. So we will choose this as the most appropriate target microcalcifications, needle and the gauge. So since we have multiple microcals, we can go for the half notch, and we have a 10 gauge needle. So we click on this, and it shows that yes, the axis is there. When it is a green button, it says it is safe, and we continue. Once this is achieved, we go to the stand, which is available as a display unit, and on clicking go, the robotic arm of the stereotactic unit moves towards the targeted position. So this is the final landing position, and now we start the procedure. So first cleaning of the skin is done once again. The next part is to give lignocaine. First, a wheel is preferred. After giving a good lignocaine wheel, we will then introduce lignocaine along the tract. When we have many microcalcifications, we can go with a little more luxurious lignocaine installation, of course, defining by the maximum criteria. However, when there is a single group of microcalcifications, it is advisable to give lesser lignocaine, and if more lignocaine is given, a check mammogram should be done to look for any displacement of the target because of the instilled lignocaine.
82. We've reached the earth. We'll get there. What?
We usually give plain lignocaine. However, when the blood pressure is on the higher side, we may give lignocaine pre-mixed with adrenaline. So this is the set of the biopsy needle, which is attached to the stereotactic unit for the machine, and the needle is attached to the driver, and the driver connects the needle to the vacuum-assisted biopsy machine. We go in smoothly. A smooth, swift movement helps in alleviating pain. So once we are inside at the target region, We start sampling for 360 degrees. We would have done a check scan again if we had instilled more lignocaine and if the target was very small, but in this case, we can avoid that. Since one round has been acquired by 6 cores, we remove the sample canister, replace it with a fresh one to acquire sample again, and meanwhile, a specimen imaging is done to confirm removal of microcalcifications. So there are various ways and techniques of specimen imaging. Here we have a separate tight volumeter to image the specimen and confirm the target while the patient is undergoing the procedure. So a separate specimen scanner or going to another machine or removing the patient is not needed. This is sample imaging confirming removal of microcalcification, so adequacy of the procedure sampling. So now for clip placement, we remove this. We put the guide inside. Core of the clip has to match the location of the needle trough for the clip to be expelled out. So once this is put, it is loaded inside. We move to the screen. What? So we deploy the clip inside, date, shutter, we sample. So the shutter is closed and it rotates again to confirm that the clip is deployed. So it's different anteriorly, we take one more view. The clip is not seen in the second view, perhaps it is overlapping the apparatus, so we just once remove the needle and confirm it. Yeah, that is a clip which is seen. So now we will remove and the procedures done.
Yes, so Dr. Aman would like to take over? Yeah. Sure, thank you.
So I guess I'd ask a couple of questions to you guys. How much compression, so what do you do once the needle is out? How much time do you give for compression? Do you give just hand compression, ice compression? What's your protocol?
So we usually give hand compression initially. After that, if there is prolonged bleeding, then we prefer ice compression as well.
And do you give the compression once the patient's released from the compression, or just while she's sitting there? And for how long? 5 minutes, 20 minutes, half an hour, 1 hour?
Around 5 to 10 minutes is the usual, ma'am. But in case there is a prolonged bleeding, we might increase the time as well.
Okay. And do you do post-procedure mammograms?
Yes.
And when do you do those?
Right now, we have started doing it on the same day, but earlier we were doing it on the next day.
Yeah. So the post-procedure mammograms are extremely, extremely important, where you, once you've stopped the bleeding, the patient is comfortable. You need to take 2 orthogonal views to show you've taken out the right area. You'll see the air gap very often there. You see the location of the clip. If your clip has migrated from where your actual biopsy is there, it's very important to document it in a report. Remember, the patient may often go for a wire localization to another center. If they go to another center, they're going to only localize the clip unless they realize the clip is 1 centimeter, 2 centimeters away from the actual lesion that was biopsied. So it's very important to do that. The mammogram also shows if there's a little bit of hematoma. A little bit of hematoma is absolutely normal. If there's a large hematoma, you can give further instructions. So what instructions do you give to a patient when the patient leaves? What are your post-procedure instructions?
Yeah, and just on a note on the compression, we give an ice compression along the point of entry, the tract, and the lesion also. So that so we have, in fact, special ice trays where we have a cylindrical ice, and then we try to compress along the tract. The second thing is generally about a 10 minutes on average ice compression is suggested, followed by a room temperature compression for about 5 minutes without the ice so that it just settles down, and then we bandage. This is in the event of not a significant bleed. And instructions, we tell the patients to continue routine activities which are light, no upper body heavy exercises or upper body yoga or stuff or weightlifting or lifting any heavy weights in general. The bandaging is such that we have a protocol of the patients coming to us the next day as well. So we do a check ultrasound for them to look at the hematoma if at all there is any. And we change the dressing on our side, and then the patient is good to go.
So generally, as she said, no, you need to keep the area dry for at least 24 to 48 hours. You need to explain to the patient there will be some bruising. For a vacuum biopsy and the patient being in compression, there's always bruising which may not be seen the same day. It may be seen 2 days later. It can actually look if someone punched them. And some people get horrified at seeing this purple thing. Infection is very, very rare, so we don't start antibiotics, but it's important to tell the patient in case they see signs of infection to let us or the doctor know, because then antibiotics would be started. It's extremely rare, but just to let the patient know what to expect. And we often give, we often give them painkillers. Do you all give any painkillers?
We see the threshold of the pain during the procedure. And SOS tablet is always recommended, and our first choice is a paracetamol only. But if there was a significant pain, then we may offer other higher anti-painkillers.
Yeah, so you generally always let them know they might feel pain. They generally feel a dull ache through the day, and they might get, and let them know they can take painkillers. In India, I think people are very reluctant to take medication, and there's no need for a patient to suffer. So just let them know they can take the Dolo. Nothing's going to happen to them if they take a Dolo that time and one later in the night. A vacuum biopsy compared to an ultrasound guided biopsy, there's a little more trauma to the breast. There's a little bit more hematoma formation. We don't call the patient back the next day at all for this. We tell the patient they're good to go unless they want to come back for a change of dressing or anything like that. But each institute has their own protocol, which is made up, and you follow the protocol of thing. I think the only thing we differ in the way you do the biopsy, we always do a check mammogram with the needle inside. It doesn't matter if there's small group of calcifications, large group of calcifications, just to show the needle is in the exact position, because it's easier to move the needle at that time than after you do your course. You find no calcifications, and if you have to retarget, there's a lot of blood. The local anesthesias are all mixed all over. So we just find it easier to do a check mammogram, and I think medico-legally, just to show that the needle was in exact position of what you were trying to biopsy is a good idea. Anything else? Any questions?
You can take 1 or 2 minutes and sum up the.
Yes, sir. And the other thing is bathing instructions. As you said, it has to be dry. So, that day, for the next 2 days, they need not have a bath. They just sponge themselves. And after the smaller dressing comes in, they can have that. And they often have concerns about the clip and about getting them detected and what it would do to them. So the way I tell them is that we place a small clip. If it is benign, forget about it. You just need to know if somebody asks, when you go for a mammogram, that yes, a clip has been placed. If it does turn out to be malignant, the clip is like a Google map location. The location for the surgeon to know where they need to go if the biopsy is positive. That's the only reason. It's a small little thing. Let it be. Don't worry.
Anyone has any questions?
Okay, well, then you can sum up.
Yeah, someone has a question.
Hi,
Yeah,
so
Magda.
I usually don't do icing because I find it from the keeping the entire area sterile point of view, I find it challenging. So if you can explain that. And I have found that without icing also fairly, the patients do okay with slightly longer compression. So 10 minutes is the minimum that I do. We don't do follow-up ultrasound next day because I assume that there'll be some amount of hematoma, and if it's large, the patient will come with a symptom. So that's what I follow. But if you are doing the practice of following next day, maybe you can tell us a little bit about that. How big a hematoma do you see? And do you aspirate or do anything about that? So just about the icing and the next day follow-up, if you can explain.
So icing sterile, once the ice is given by the sister, the resident or anybody who's assisting in the procedure has a sterile green sheet with them. The ice is just delivered on that, wrapped it up and kept. So it remains sterile throughout. And about the
next day hematoma.
So most of the times there isn't a significant hematoma. Yes, we do not do anything about it. But again, wanting to keep it aseptic and our patients are around over here, we prefer to them come down the next day. We change the dressing for them and that time it's a sterile ultrasound done again for the hematoma. It's usually not a significant hematoma.
Okay, great. Thank you.
Thank you so much.
Does anyone have any other questions?
Thank you, all of you. We'll
you,
move
sir.
into the next session.
Thank you.
Now we will be having CEM guided vacuum assisted biopsy. Palak will be doing whole job of demonstrator and moderator. And I invite Dr. Kunal B. Gala. He is Associate Professor Interventional Radiology at Tata Memorial Hospital, has an experience of 8 years in the field of intervention radiology. Dr. Kunal Gala.
Thank you, Dr. Raman, and thanks, Kunal, and thanks, Somishri. Welcome, Kunal. So I am sorry, but I'm filling up for Dr. Niketa. I'm sure you would have wanted to hear her, but her flight is delayed, so she'll be joining us a little later. So I'm filling up for her for the contrast-enhanced mammo-guided biopsy part. And in view of time and not having a lot of repetitions, we thought, let us club these two together. And we just show the relevant changes that are needed from a stereotactic guided vacuum-assisted biopsy. So this time the video is going to run at a 4x speed. Right. So apologies, I'm talking on behalf of Dr. Niketa Chotai. So this is the unit that you need to have for contrast-enhanced guided vacuum-assisted biopsies. Since we had fewer members in the limited workshops that we had yesterday, so for the ones who were not in the workshop, just a 5 to 10 minutes on what is a contrast-enhanced mammography. It is digital mammography with administration of IV contrast. It's your CT contrast. Similar to MRI, it allows visualization of tumor neovascularization. Dual energy mammogram is acquired about 2 minutes after IV injection of iodinated contrast, but we personally find a benefit in even starting at 1 minute. Customized protocol for biopsy, as I said, can be 1 minute. 2 paired images are acquired, a low energy image and a recombined image. So the benefit may be in various terms, such as detecting occult disease. So for example, this is a bilateral CC view of a dense mammogram. There is an obvious asymmetry with a little bit of buckling and architectural distortion here. Running a contrast mammo in this case definitely showed additional non-mass enhancement apart from the expected site of disease. Multifocality may be detected sometimes, so there is obviously an abnormality, a small speculated mass that we are seeing here in the far upper outer quadrant, and perhaps a retroareolar density in the CC view, not as well apparent in the MLO view. And when we look at the contrast-enhanced mammography, we do find additional areas, not just where we saw, but there were also intervening areas which were positive on histopathology. Multicentricity may be detected, again, in obvious disease, and there was another area to just show that image again. This area it was not even a very dense parenchyma. So just to show that when you have an elephant in the room, we need to be doubly cautious about seeing other areas. And this was the satellite, the other area was also positive for malignancy on a separate histopathological imaging. An occult disease and finding a primary, so this was an enlarged axillary node, it was suspicious, and there was just a subtle non-mass enhancement that was seen in the upper aspect, and that was positive. So what are the indications for contrast-enhanced mammography? Any inconclusive finding, preoperative imaging, response monitoring, screening tool for women with increased risk, dense breast parenchyma, asymmetries, and architectural distortion. In my opinion, it would be worthwhile for diagnostic mammograms who do not fit into absolute or appropriate indications for MRI. So now coming to what are the indications for a contrast-enhanced mammography guided biopsy. It is an alternative to an MRI guided biopsy, and its availability, its cost, claustrophobia gets eliminated, anthropometric limitations for an MRI, and contraindications to an MR. What does it require? A specific biopsy hardware add-on to the mammographic equipment and dedicated software upgrade that applies the dual energy acquisition to the stereotactic equipment. So the technique is that we identify the site. So we have a left breast disease. We have some disease here and some enhancement over here.
And this did not have a correlate on ultrasound. The lower central disease was very obvious. So this had to be biopsied because the lady was very certain she wanted to have a breast conserving surgery. Young woman, 39 years. So look at the breast. When I talk about the compression and how does it matter. So we have an upper aspect and we have a lower aspect. Now, if we are going to go vertically down in a vertical approach, we have certain limitations. If the site is very close to the base, we can hit the paddle. And of course, there is a skin injury. And it's a through and through. And if we are very close to the skin, there is a risk of skin tear, which is not as bad as the first situation, but still. So there are certain restrictors for your choice of approach. In that case, so the aperture of the needles that we generally use along with the dead end is about 2.5 centimeters. So a small heads-on is if you've done a mammogram already, we have now made it a protocol in our checklist to look into the compression thickness. If in the mammogram it is a small breast of 2 centimeters, planning her for a stereotactic and a CM guided VAB and everything may not be the best prudent approach. So it needs to be given a thought of, is there an alternative approach? In that case, we may choose a flipped horizontal. So if the breast is like this, we go in through a flipped horizontal approach, provided the target is somewhere within the center. Because again, if you're very close on the top or the bottom, there can be a skin tear on either side. So that is one option in a thin breast if you are somewhere in the central zone. So this is how the vertical approach is in the breast. And this is how a flipped horizontal approach would be. So if you are somewhere in the center or middle thirds, it is okay. But going too close on either side, again, may be a blind spot for you. And then these are the few cases where we may target by a hook wire localization. So these are the steps of entering. Now, I think we would just run through a very fast video. One point here is, when we look at a contrast-enhanced mammo-guided biopsy, we struggle with one area, and initially it took some time for us to figure out. So this is the area we have decided that a vertical approach is going to be good for this patient. And when we acquire, there is a digital zooming happening on the acquisition workstation. So if you see a very nice lesion on your diagnostic CEM, it doesn't look that good when you start going ahead with a biopsy. So there are two factors. One is there is magnification, so it looks different. Second is the resolution. The resolution of the acquisition console inside is usually about 2 MP versus the resolution when you're going to read your diagnostic imaging. So that changes the resolution significantly. So it may be a thought that you may consider getting higher resolution acquisition work consoles when we are going to get ahead to doing more procedures. So this is how it looks. We have a central view, we have a plus and a minus 15 view. The target is chosen, and then we go ahead. So we choose a coordinator, the coordinators are put in the right position. We check that it is conforming to the site we have chosen in the 0 degree, and then the procedure is done. And after the procedure is done, we prefer to withdraw the needle. In a stereotactic biopsy, the difference is you have microcals and they are targeted and you see them on a specimen scanner. In a contrast mammo, there is no way we can prove it. So the only best thing is that we can remove the needle, look at the air focus, confirm that you were there, and on the console, this image is going to be shown just below your image where you have placed your target region. So you know, yes, you were there at the right site. So that is how we confirm, and a 4x speed. So this is how the trolley is prepared, as we were told before also. So we coordinate the So when we are actually doing a CM-guided biopsy, the acquisition first happens in a 2D image, and then it gets subtracted. So we have to wait for every time the 2D mammo gets replaced with a contrast-enhanced image for each step. Now again, so this is a 2D image, and this is not a contrast image. So the cores are acquired. We also do a saline vacuum every time because sometimes a vacuum error can happen in the system and we can get stuck in the middle of the procedure. So it's good to have a vacuum check done at all times. And this is how the core biopsy looks. So this is an example of how, targeting by CM biopsy. So here there was a lesion and a small satellite lesion. This was positive for malignancy, so it helped. This was our first patient. This is an obvious disease on the right side over here. And then we have some non-mass enhancement on the opposite side, and that was biopsied, but that was benign fibrocystic change. This is another patient where we have obvious disease on the right side, and there was something on the MR detected on the contralateral breast, and it was very obvious, so we converted. There was no relook ultrasound finding for this. There was something which matched and triangulated, and we performed a CM-guided biopsy. So this is how the CM images look when we are doing a CM-guided biopsy, and that was confirming, and that was a fibroadenoma. Another non-mass enhancement, which was otherwise not seen, more like an enhancing asymmetry. It was a benign lesion on contrast-enhanced biopsy again. And this is another example where there's an obvious disease and an asymmetry on the opposite side, and this was positive for malignancy, and she underwent bilateral disease. It was an invasive micropapillary carcinoma. Again, another disease, she was on routine follow-up for multiple fibroadenomas for a long time, and the CM detected certain enhancing areas besides the elephants that we describe always, and this was positive for malignancy. Yeah, so some tips and tricks that I would suggest over here. One is ask for a higher resolution acquisition workstation. That's something we had never thought of. A careful review of the prior CEM is important. Note the landmarks of anatomy, vessels, and calcifications, because on the day, the enhancement can look really different for the reasons I said. Note the distances from the nipple and the skin beforehand, so you're sure, because when we are seeing the CM, it's the entire breast, but when we take her on procedure, we just see a small area which is magnified, so there can be some challenges there as well. Menstrual phase to be noted in the prior scan and the biopsy scan, because when we are dealing with non-mass enhancements, that can be challenging as well, so it's good to know what to expect. Prior skin marking can be done in the center of a compression paddle, because every time you are going to release and recompress for a CEM, you have the boundaries marked, because here we are not seeing microcalcifications. Start early acquisition. We find help with the 1-minute acquisition. And in the post-chemotherapy setting, we need to wait for delayed enhancement because we may not expect early enhancement. Use combination of the horizontal approach and the flat paddle. So when I talk about a flat paddle, again, the third cause for a poorer resolution when we do a biopsy is that there is a fenestrated grid. So when there is fenestration, there is release of compression in that window, and that results in poorer or suboptimal resolution of the image that we see. So in a contrast-enhanced mammo, it may be helpful to use a flat paddle for uniform compression of the breast and use a flipped horizontal approach so that the target is seen better. A bold skin nick must be used for avoiding snow plowing. So this translates from an MRI-guided biopsy. So how does it matter? When we go ahead with a stereotactic biopsy, it's a firm breast and we are going ahead without any resistance. But if we have to go in a flipped horizontal, we are going horizontally where there is no pressure on this side. The compression is like this, and we want to go from this direction. So it is going to have a significant slow plowing effect. Hence, a bold skin nick is going to be helpful to have the straight visualization of the tract of the needle. And we remove the needle for confirmation and showing the presence of air at the site. Of course, we do put a clip also, and we do a check mammogram also. Complications can be pain, bleeding, or bruising and hematoma, skin tear, or damage to detector, usually avoided by software, but not always. The software is eventually a software, and it cannot replace our eyes. We have found instances where the software might have misguided us in terms of a collision risk or a posterior risk. Especially if you're using a horizontal approach, the software cannot detect whether you are going to cause a skin tear on the top or the bottom. So it has to be our judgment from the side to know where in the middle of the breast you are in a compressed breast. Complications associated with local anesthesia. we've not encountered. Associated with iodinated contrast media, we have to be vigilant and watchful at all times. Vasovagal complications, infection, milk fistula, implant rupture, we don't really encounter them. Vasovagal complication may happen the moment the patient feels. It's good to be talking to the patient all the while. It usually makes the patient comfortable and active during the procedure. Radiation exposure is a limitation, and background parenchymal enhancement masking the target lesion is also a limitation at times. So my take-home message would be image wisely, triage well, don't get too aggressive with going ahead with all biopsies. Be cost effective. If something very obviously seen on the MRI may be put out here, it saves the cost by 1/3. With CEMs increasingly available, CEM guided biopsy appears promising. Avoid unnecessary biopsies. I would always say that. Care and compassion for your patient. Thank you so much.
Can I have one or two questions?
Sure, ma'am.
Suppose you're biopsying a malignant lesion and washes out by the time you are trying to arrange everything.
Right.
What do? Give it contrast again?
No. So, like in MRI, we also had the same concerns before, but our initial target is going to be what we have seen before. Whether the lesion washes out or it doesn't, later on, whether it washes out or not, we have to be where we were because we've gone inside and we are going to do the procedure. So like in MRI, an MRI can take almost 30 to 40 minutes and lesions are going to wash out. So it doesn't matter if the lesion washes out or not. Catching it at the right moment when it is first seen is what we need to do. The later we go, there is background enhancement that comes up and that becomes limiting. But then we stop looking at the enhancement features. It's the first image that we want. Which is why rather than 2 minutes, we propose to go and start acquiring by 1 minute. Actually not. We just see the first image and then that's our target. Then everything else is like a stereotactic, which is why I did not have that biopsy, the video. Everything is like stereotactic. The only difference is instead of targeting microcals, we are seeing the CM. Challenge is the resolution that I spoke of. Yes, that is definitely challenging. And I hope the vendors and the companies come with better AI software. So this is what I tell them all the time. The images during doing the biopsy need to be better, but 2-3 pointers like the acquisition workstation is what next time I think we will try for a 5 MP acquisition workstation console monitor.
Like something we have on angiography roadmap kind of. So
Yes.
we can have something there also which can show that where is the right result.
Yes, waiting for them to upgrade those softwares. Absolutely, yes. It's time it starts coming into it, yes.
Ma'am, I want to ask one question. What do you check in the check mammogram, like the specimen mammogram, then what do you check in that, in the contrast enhanced biopsy?
So we cannot check because it is perfusion based, just like an MRI guided biopsy, which is why the only thing that we have left with us is that when we can withdraw the needle. Okay. So in the console, there are 4 images. The first 2 images on the top show you your target with the plus sign, and the bottom 2 images will be the needle withdrawn, and you see the black air gap seen just below it. So one suggestion, whenever we take that check image, we vacuum thoroughly because we don't want that little pooling with blood to happen. Again, this blood has iodinated contrast already inside if there is a hematoma. So sometimes you either find a nice air void as I showed, or we can find pooling of contrast over there, which is also the site of biopsy, but because of the blood containing contrast which has pooled out there.
So, thanks, Dr.
So honestly, if there is a convincing target, we will. Otherwise, if it is very vague, we might resort to an MRI. I am sorry, it is not good as a radiologist to say now this and then this. But biopsying on a hunch of random non-mass enhancements, I would not be comfortable with, because you would never know whether you put in the needle at a right place or not. So that is one major limitation of a CEM. It happens in probably very few patients, but then I think we do need to resort to an MRI. No. Then we would base our, so if that patient goes for an MRI, there are very few indications. One of them is this. We would look at the enhancing features and the entire MRI together.
a lot of doubts would get eliminated. And another thing, if there is one disease and there are multiple other areas which are overlapping and stuff, or ductal pathologies, we wouldn't do CEM, because one limitation of contrast mammo is, at the end of the day, it is two-dimensional. If you have multiple significant findings in 3 quadrants based on an ultrasound or mammo, there's no point doing a CEM. If you want a better functional assessment, go ahead for an MRI. I'm talking in view of a lot of breast conserving surgeries that we do despite having solid 2-quadrant diseases. So for us, 3D characterization sometimes becomes important.
Thanks, Dr. Palak. You explained very excellently.
Thank
so
you,
I
sir.
request to next ultrasonography guided vacuum assisted breast biopsy, Dr. Kunal Gala, Dr. Rupa Ranganathan, and Dr. Bhavna. Dr. Rupa Ranganathan, leads consultant breast and women's imaging and interventions director, breast center at Kovai Medical Center and Hospitals, Coimbatore, Tamil Nadu. Course director and FNB breast since 2019, joint secretary Breast Imaging Society of India, founder member and secretary of Society of GI Imaging.
That's my picture.
Dr. Bhavna Dev, professor in charge of women imaging, lead radiologist, breast imaging and interventions, Sri Ramchandra Institute of Higher Education and Research. Areas of interest, breast imaging and interventions, MR guided focus ultrasounds, MSK interventions, intraoperative ultrasound guided procedures, more than 80 publications, as peer review national and international journals, experience in teaching hospitals and university for more than 20 years. Dr. Bhavna Dev.
Thank you, sir. I see the first person yawning. So the idea is basically, actually this should have been the first talk, but we got held up in the traffic, so this has come last. Because why I'm telling this is because this is the most common thing. And I am going to take actually test of Kunal. I didn't tell him that because I thought if we interacted, this is very practical. See, ultrasound guided VAB is like, at least we can start doing, all of us can start doing it. So Kunal has made a small presentation. Palak and everybody, the prior speakers have told you about indications and what are the complications and all that. That remains the same. But the technique obviously is different and it is much more simpler. And all of us can do it as compared to stereotactic contrast enhanced mammogram. So Kunal has made a small presentation. Kunal, would you like to come here?
Good morning, everyone. Still good morning. Regarding the VAB in ultrasound guided, it is safe, it is cost effective, economical, and it has no radioactivity as opposed to CEM or mammography guided VAB, and it is real time. So that's one major thing which is lacking with CEM or ultrasound guided as compared to MRI or other things. So there is level 1 evidence for diagnostic and therapeutic intervention with VAB. Coming on to the indication, so it's broadly divided into diagnostic and therapeutic. So for diagnostic, it would be for palpable or non-palpable ACR BI-RADS category 3 lesions or a small lesion, that is 4A lesions, invasive lobular carcinomas which are infiltrative type, inadequate FNAC or cold needle biopsy results when there is discordance between the RAD path. That is the time we do ultrasound guided VAP, small for solitary papillomas. And when the smaller lesions less than 5 centimeter are mainly stellate lesions and microcalcification. So these are predominant indications where we need to do diagnostic VAP, and wherever we can see the lesion on ultrasound, then we do ultrasound guided VAP. Coming on to the therapeutic indication is for either if you follow AC American Society, then they tell complete excision of fibroadenoma less than 4 centimeter, and when you follow the European guidelines, they are 3 centimeter. And another indication is solitary papilloma as a therapeutic indication. So coming on to contraindication, so the size of the lesion, if they are more, the size, that is where you can do biopsy of those lesions. So then it becomes one of the complications. Obviously, patient should not have any bleeding tendency, coagulopathy, or other blood-related disorders or dyscrasias, and patient with systemic disease who cannot tolerate surgery. So predominant advantage here is lower histological underestimate as compared to the biopsy. It is more accurate with lower cancer miss and ability to target larger tissue with a contiguous specimen. Acquiring multiple specimen with a single needle incision, and obviously removal of benign lesion like fibroadenoma is also possible with VAB. The advantage under ultrasound guided are predominant because you can visualize the needle, you can visualize the lesion and the needle, and it gives less error and gives more confidence because you can see the needle through and through. It is more comfortable because you are talking to the patient continuously. Patient is not under the pressure also because of the compression of the compressing pedals. It is non-ionizing radiation and does not cause any harmful effect, and it takes much lesser procedure time compared to any other procedures. So coming on to the equipment, I think everything has been shown previously, and this is the instrument of the VAB. So this is a needle, either it could be 7 gauge or 10 gauge depending on the company which you are using, and this is the main instrument which has a vacuum and the suctioning on the handheld system, and there is a foot system as well, and this is a canister where the tissue is getting collected. Like any other pre-procedure workup, patient counseling is the foremost important thing, and obviously we need to see the imaging also of the patient prior to doing any biopsy. So maybe from here we can carry on. Dr. Bhavna? Yeah, after this. So this is the patient, 43-year-old lady with no comorbidities, a small breast nodule, and this is what it was there. It was probably not visualized, so it is probably here and not visualized on CEM. And on ultrasound, it was maybe a 5 centimeter lesion with the lobulated margins. 5 millimeter. 5 millimeter. Yeah, 5 millimeter lesion, probably lobulated margins. So probably BI-RADS either 4A type of lesion. Since it's not visualized on CEM, maybe I would undersize to BI-RADS 3 or maybe 4A type of lesion. So normally on the CM, you go beneath the undersurface of the lesion so that all the suctioning gets on the top of it, and then all the suction material comes in. So this is what it is. Yeah, so I have started the video.
Yeah, so as Dr. Kunal had shown you, can you just pause 1 minute?
Yeah.
So he had shown you a case, the case 1 he showed, it's a 5 millimeter lesion, okay. So now actually the trend is coming, more of oncosurgeons and all, they are asking us to do VAB because VAB is also very commonly, it's available easily. So instead of getting a core biopsy of a 5 millimeter lesion, they are asking to do 5 VAB biopsies. What is your experience on this?
We still do a true cut biopsy, and vacuum is done only for a suspected B3 lesion or for a therapeutic excision still. Yeah. For such lesions, if it is an intraductal, if it seems to be an intraductal, maybe we would consider a VAB. And I would, before we go into the procedure, there is one point that I would like to add in your indications and contraindications. In contraindications, if the imaging is suggestive of a phylloids, but the histopathology is fibroadenoma, we would still not consider VAB in that subset of patient, considering that as a RAD-PATH discordance. So we will have to recommend it for a surgical excision. Though there are papers for vacuum-assisted excision of benign phylloids, still it has not come into the guidelines because of the high recurrence rate. So even if the histopathology is fibroadenoma, but radiologically you feel there is a possibility of a phylloids, we avoid. That is one of the contraindications that is mentioned in the American Society of Surgeons, along with the 4 centimeter indication.
Yeah, also when you begin to do VAB, we are all excited. We want to do a lot of patients, okay? We want to excise fibroadenoma. So pathologists sometimes, obviously, before you do VAB excision of a fibroadenoma, you need to do a biopsy and prove it to be a fibroadenoma, as she was telling. But sometimes the pathologist will give you a report of fibroepithelial lesion. Okay, so you have to be very, very careful. Okay, so don't get into that trap, if it comes as a phylloids later, as Dr. Rupa was telling. So you have to believe your morphology. Okay, and if they have given fibroepithelial instead of a, clean fibroadenoma, so you have to be a little cautious. Anything?
But if it is if you think it's a fibroadenoma and you had gone in for a therapeutic excision, imaging concordant as fibroadenoma, pathology, initial histopathology was fibroadenoma, but the final excision comes as benign phylloids, we can still leave it without recommending them for surgery and keeping them for follow-up. So if the image and the RAD-PATH was concordant with fibroadenoma, but the final excision histopathology turns out to be a benign phylloids, there is absolutely no indication for them to be referred for a further surgical excision, and they can be safely followed.
So did you do biopsy for this patient?
No.
Directly excision?
Because patient did not want the surgery and wanted to remove everything at one go.
Okay. So in this case, they have, what patient wanted, they did that, okay? But otherwise, this lesion looks quite microlobulated and looks quite suspicious.
Yes, he.
So the probability of
being a benign
three,
the probability that it would turn out to be an invasive cancer is less.
Is less,
yeah. So low probability, either it would be 4A or 3, depends if you have done CEM, then probably 3. And if you look at the ultrasound image, then there are some microlobulations
the point here which I wanted to bring is that if you see a lesion like this, definitely it has to be biopsied if you are thinking of excision. Okay, so anyways you did CEM and patient didn't want it, so it makes sense, to go ahead and do a excision.
Okay. So here, so we have we are marking.
Explain the steps.
Yeah. So we are marking the lesion as well and giving local anesthesia in the skin and subcutaneous tissue. After giving at least 2 to 3 cc of local lignocaine, that is either you can use 1% or 2% lignocaine, and you should go up to at least 10 cc of lignocaine all throughout the lesion. And since it is placed anteriorly, so good amount of hydrodissection would be also required in this case, so that the lesion pushes on the posterior edge as well. So this is how the local is infiltrated. So first give on the skin and subcutaneous tissue, and then probably you can go inside more deeper and visualize it. Give local all throughout, and this is how the hydrodissection is done, so that the lesion goes more posteriorly and So another thing is we are giving after giving local anesthesia, wait for at least 5 minutes so that the local keeps on acting, and after that just give a good nick so that.
Kunal, so what is the other thing that we usually do in ultrasound guided VAB is, we are not going to take a full clock, rather we go only posterior and use a 12 o'clock position. So we will also make sure that before making a nick in the skin, we'll make sure that the needle site of puncture reaches the posterior aspect of the lesion without any issue. So sometimes for the lesion which is which is located more posteriorly, if your skin entry is not far enough from the probe, you may not be able to reach posterior to the lesion and then make it parallel to the chest wall. So that will be a big challenge. So we always use a spinal needle loaded with saline, mixed with anesthesia, and go to the posterior aspect and see whether the site of entry is optimal before making a skin incision, so that we don't repeat the skin incision by, if it is posterior, you might try to manipulate, you may not be able to reach posterior and also parallel to the chest wall, so you may have to repeat the skin incision. So this is a very important step that you need to follow, because we are going posterior and not into the lesion like a true cut biopsy, and we are not going to take a full clock, we are going to use only 12 o'clock. So your position of the placement of the probe is very crucial. So this part of planning is very important.
One second, Kunal. See, actually in this picture, whoever has understood, but if you see, usually when we do, we'll put the probe here. Okay, that is for if the lesion is interior. If what Dr. Rupa was telling is if lesion is posterior, you have to go a little further from here. Okay, and then you give it incision so that you are parallel. Okay, that is very important. Positioning, when you go in, once you have gone in, you are done with the procedure. So positioning is the one thing which is very, very important. So you have to take care of that.
So maybe 1 or 2 centimeters depending on where the lesion is located and where your incision
And
would
what
be.
she's telling is try it with the spinal
With the
first.
spinal,
Use a spinal, and you will need at least more than 3 centimeter when the lesion is
Yeah,
posterior.
posterior.
So it comes out of practice, we really don't have to measure, but as and when you do it, but you have to remember this step so that you don't make a second incision or you struggle. Many a times, we try to manipulate the needle with the first skin incision made, and we struggle throughout the procedure. Instead, we have to realize that we made a wrong marking in the skin and then move further and make a second incision. To avoid that, if you use it as a protocol every single time, that I infiltrate with a 22 or a 24 gauge needle, the skin and subcute, but I also load the saline and use a spinal G. Mostly on a thicker breast, we may have to use an 18G because you will not be able to pierce with a thinner needle. Make sure you reach posterior and then you make the skin incision. So if you do it as a regular protocol, we don't struggle, or we don't have to make a second incision.
So, so if the lesion is located posteriorly, that is on the pectoralis, you need to lift the lesion. That's why we need to have a good hydrodissection. And this is after inserting the needle. So needle, so there would be some jerky sensation while insertion. So this is the most difficult part of the journey. After that, it goes on very smoothly and easily. See that jerk normally comes. So if the incision is good, then this jerk can be avoided. And just localize the lesion and the needle as well. And we always go underneath the lesion rather than over the lesion or into the lesion. Okay. So this is how the needle is positioned. And this is how the cutting edge of the needle is. So this is how we can maneuver the wherever the lesion is located accordingly. And but on ultrasound, it's always at 9 o'clock to 3 o'clock position. This is how the vacuum is happening, and then you can rotate it and suction out all the hematoma or everything.
1 second. And
Yeah.
Dr. Rupa, do you follow the same technique or is it different?
Always use a 12 o'clock.
12.
12 o'clock position. We don't change the clock positions on ultrasound. Rather, we actually use the maneuver to rotate it medially and laterally, because this has a better control rather than changing the clock. So it is always 12 o'clock, and we move it on maybe to 11 and 1, or extreme large fibroadenomas at 10 and 2. And another thing is, you have used the BD, right?
Yeah.
VAB. So for a 5 millimeter lesion, you can use a half throw. You are not suspecting a malignancy in this. Even for a 5 millimeter lesion, 1.1 centimeter will be the half throw aperture sample knot size. So we can avoid taking lot of normal breast tissue for such a small lesion which have a very low malignant potential. So you can, instead of using a full sample notch, you can use a half sample notch here, and take only that 1 centimeter component. Do anybody else who is using VAB have the practice of using, apart from 12 o'clock, as 9 and 3 here?
12
Yeah. Have a better control rather than actually doing it from 9 to 3. Yeah.
Yeah, so basically what all of us are telling is, if this is the lesion, yeah. No, it's okay. So we keep the probe here, okay, 12 o'clock, and it keeps sucking, and we just move like this, little bit, okay, so we don't change it, that's it, it's very simpler. And this notch can be made half, actually. This is in the system machine. You just have to click, it will become half notch or full notch. For smaller lesions, half notch, and keep the lesion keep the needle like this and just keep moving like this if it's a bigger lesion. Otherwise, just keep it here, 12 o'clock, it'll suck.
For this lesions, half sample notch, and just at 12 o'clock will be more than enough to completely remove this lesion. Yeah.
Yes. And this is how the clip placement, either you can do through the needle, or if you don't have the needle that time, you can do with the other BD needle as well. So this is the marker placement which is done.
We use ultra clip, so we may have to remove the probe and put it in, unlike what we do it in stereo, where that goes within the sample container.
So this is how, after removing the needle, the clip marker is placed, where the and this is how the sample is collected into the system.
It is the same. Post procedure is pretty much the same like other biopsies.
Okay. I think so that's it. So this is what we have covered. Whenever it is a tough fibrous lesion, VAP can be a little challenging. We can do hydrodissection. If the lesion is located anteriorly, you need to have a good hydrodissection anteriorly, or if it is located at the posteriorly along the pectoralis, then you need to lift the lesion anteriorly so that you go beneath the lesion.
This hydrodissection, superior and posterior, helps to avoid skin and pectoralis muscle injury. But to navigate through a very dense breast tissue, even the spinal check that we are doing, if you infiltrate a little bit of saline, it helps for easier navigation of the probe in the denser breast tissue as well.
Yeah. So that's it. These are predominant differences, and the complications
are
remain
also
the
the same.
same for most of the things. Okay.
Well, if there are any question from the audience.
As far as the clip placement goes, once you've taken out your whole assembly, then how do you know exactly where to place the clip?
What I
if it's
practice
in the small lead.
What I practice is the person who assists me actually keeps the marker ready, and I don't remove the hand where I had kept with the probe. The probe hand doesn't move. I only remove the vacuum probe outside. The ultrasound probe hand still remains in the same place, and my assistant gives me the marker and I inject it. So my hand does not move for smaller lesion.
Yeah,
that's what I do.
That's how practical basically it should be done.
Yeah. And on ultrasound, you can see some defect.
But if it is a very small introductal, you wouldn't. You wouldn't.
Yeah, so
Yeah. So that is a practice that I do. I don't take my hands off the breast. Yeah.
Okay. Any more questions?
I think that sums up the.
Jwala, what?
Because this was an example that you showed, but you wish it's not malignant because you have a CSM. But for the listeners, I just want to be very clear that because he did contrast, it's not working.
Your voice is enough. Speak up.
He was sure it's not going to turn out to be malignant. At the most, it would be a B3 pathology. But if we don't have a CSM, you will biopsy this before you do a valve excision. All right?
Yeah, that we made. Yeah, biopsy is must before. that. Yeah.
Okay, I think let me thank you, Dr. Kunal, Dr. Rupa, and Bhavna.
Thank you,
as
sir.
usual. We move on to the next topic. Enhancing precision, the role of GAD-based contrast agents in breast MR. And I call upon Shweta Arora for delivering this talk. Shweta is a medical scientific liaison in Gurbay, India, and she has done PhD in management of diabetes and obesity, working in MNC group for 13 plus years, and medical strategy building. Okay.
So, thank you, sir, and it's really a warm welcome, and it's my privilege to present my data in front of the key experts. I think I'm also a learning phase. I joined just the Gurbay 1 month back, and I'm learning the thing, and I'll be presenting my publications on the gadoteric acid breast DC MRI. Next, okay. So as my introduction already done, I'm a medical scientific liaison working in Gurbay. From India, from medical team, I'm presenting to my France team as well as to the India team. The studies which we are gonna discuss, I'll be very brief to the studies because I'll not go into much of the details of the same. So first is the response of the new adjuvant treatment of invasive ductal breast carcinoma, including the outcome evaluation, MRI analysis by automatic CAD system in comparison to the visual evaluation, as it's just resonates with the fact that what's the key difference between the CAD and the visual evaluation. I think the visual evaluation always outscores the CAD, and we also have the comparison of the gadoteric acid and gadobiturol for detection as well as for the changes in the morphological as well as the dynamic features when we are comparing both the contrast agents, although both are macrocyclic contrast agents, but we'll be looking at the difference on the basis of the CAD as well as visual detection on the basis of the curves, which Palak ma'am was explaining on the same, as well as we'll be also talking about the what is the change in the curves and as well as the various the contrast agent, how they behave in the same. So the first publication we'll be talking about as the so the neoadjuvant therapy basically done to just downsize the cancer and to it's to overall improve the survival rate, pre-survival, and also when we use a contrast, what is the there is pre-NACT contrast images, there is post-NACT. So we'll be looking at the difference between both of the images in the same. So then MRI images were taken, the evaluation was done on the basis of the CAD and as well as the histopathological response to the NACT before and after the comparing both the images together, and also the occurrence of the metastasis, whether our NACT is expecting to see how the metastases have gone or not, whether the curves are saying, whether the continuous, not continuous, plateau, or what it is. And in this protocol and all, I'll not go into much of the details because it's quite visible in the fact, but I'll be going in the fact that the 54 women were there, and Bio-Rad's classification were 4 to 5, and in NACT, when the treatment regimen was done, there was a cyclophosphamide, doxycycline, doxorubicin, doxorubicin was 500, doxorubicin was 50 milligram, and there was a breast conversion surgery with few people, or mastectomy with few people, and there was a histopathological margins were also seen, and the people who have undergone the breast conversion surgery were also given the axillary lymph node dissection and radiation therapies, and the hormone also, depending upon the status of positivity or not, it's not positive or positive. So depending upon this, then we come to the MRI protocol, that is the gadoteric acid injection 0.1 millimole, and the tumor classification was done on the BI-RADS MRI atlas, and they have seen the various classification on the fact that what is the difference between the visual as well as the CAD, how are the curves going, and NACT classification on the basis of the RECIST criteria, complete response, partial response, or the progressive response. And most of the people, they were landing in the partial response in this study. And the tumor histopathology, when we talk about, it talks about the evaluation to the NACT, I mean, what was the change? Although the change was not very much, but it was seen as after the NACT, the change, there was a change seen in the MDI index, which we'll be talking about in the next slides. And then the diagnosis of the metastasis, how the metastasis have progressed or not. And every 6 to 12 months, they were there in the follow-up to see whether the metastasis was undergoing or not. And out of the 54 patients, the 12 patients, they have gone into the fact that into the 12 in the malignancy range. And then we come to the tumor characteristics on the fact that it lies between the 2A and 3, I mean, most of the benign category, ER positive. And what was seen in the fact is that when we have seen the images, when we have compared the CAD versus the visual one, we have seen it's just resonate with the fact that with the CAD we can see the specificity to be more, sensitivity to be less. So when the visual, as you guys are the best expert in determining the fact that what is the giving the lesser number of false positive, whereas in the CAD it has given 100% on the basis of the specificity part, as compared to the sensitivity was lower. But when we talk about the diagnostic accuracy, it was seen to be 87% versus 63% in the CAD. So which outscores the other, it's quite significant as the clinical practice. So then this is a C. After the NACT, we can see the size in this thing has been reduced. So red and the blue, the yellow one after that, the sizes have been reduced. And see the curves when we talk about, then the curves were more continuous and lesser washout period after the NACT, and which is quite significant in the real practice also, and lower in the case of the initial spikes, and the more of less continuous was there before NACT. And the response to that after NACT that we have talked, the carcinoma morphological differences were not common. So as we discussed, the washout curves were significant pre-NACT, and after NACT it was quite lesser. And when we talk about the discussion part, then we have already discussed that the specificity part, sensitivity part. Specificity part, when we talk about, was more with the CAD, as the sensitivity part was more with the visual. And as well as the morphological differences were not too much. And the false negatives were seen majorly with the CAD, and there was more washout period pre-NACT, and the post-NACT, the curves were more continuous, and the meta curves were seen over the period of time. So I'll not go into the details. Now I'll go to the second, this thing in which it is compared also on the basis of the CAD as well as on the basis of the visual evaluation on the two types of tumors. One was a benign and there was a malignant tumors. And the comparison of the two GBC agents, both of them, they are macrocyclic in nature, but one is ionic, one is non-ionic. So we talk about the gadoteric acid and gadovitriol for detection of the morphological and dynamic characterization of the lesion and the breast dynamic contrast enhanced magnetic resonance imaging. Sorry. Okay. So this we already have talked about the role of the CAD, and the BI-RADS MRI atlas is the key, and it's a guide which gives the proper demarcations on the fact that where to just grade the cancers on them. So then the aim of the study was to have although the dosages were similar concentration, but we know that with the gadobiturol, the concentration is twice. So that we have mixed that concentration, try to make that concentration similar by mixing more saline, but the concentration is among all the GBC agent, it is 1 millimole per kg, as compared to the others, they are 0.5. And we have compared the crossover studies, and 2 blinded readers were there. So then the injections range was same as I talked about, and the evaluations range was same. And the important parameter was the morphodynamic index, MDI index, which assessed the probability of malignancy from 0 to 100%. Okay, so out of the 45 patients, they lie in the range of BI-RADS 4 and 5. And 51 lesions out of the 41 lesions were seen to be malignant, and 10 are benign in nature. And even the CAD evaluations were not very significant, and they have detected 39 malignant tumors and 10 as a benign tumors, and rest of them were picked up by the visual people, and a detection rate was 96%, and the tumor size and the morphological differences were not changing in both of the contrast agent. But when we talk about a head, because of the higher concentration of the gadobiturol, the accumulation in the tissue is significantly more, which was responsible for the more relaxivity in that case with the gadobiturol as compared to the gadoturic acid. So the smooth curves, when we talk about, they were seen more with the gadoturic acid as compared to the little haywire curves were seen, and little more pronounced curves were seen with the gadobiturol. And when we talk about the curves part, the lower initial spike was more with the gadobiturol, and then there was a plateau, whereas in the case of the gadoturic acid, the more washout periods were seen, and initial spike was not much. So you can see the smooth pictures first with the gadoturic acid, and the little irregular with the gadobiturol. And so you can see the spikes. As I was talking, this was in the malignant case. Initial was high, and then there was a washout, and gadobiturol, the initial was little more spike, and it was more of the plateau at the form, more than 300%, and then it has reached the plateau soon. And then it was more continuous in the benign, which is the common case, which is seen that with the malignant, you will just get the sharp spikes as compared to the benign ones. It's more of the continuous forms. Although the contrast plays a less role in defining the curves, but still they have seen some of the effect on the same. The diagnostic accuracy was seen with both the contrast agent to be absolutely similar. And the relaxivity part, this is important in the fact that when we compare both of the contrast agent, I think the contrast has a little role in defining the curves, but due to the higher concentration, the mixing was more. And the T1 relaxivity, which was seen with the gadobiturol, was more. And then I'll finish it off. And there was a weak binding. Because of the weak binding, it just started accumulating in the cell. And being a neutrally charged, not the negatively charged, it just moved quickly inside the cells, as compared to the gadoturic acid, which is negatively charged. It repels the negative charges which are there on the cancer cells. So the accumulation part is little less. So that's it. Diameters were little higher, margins were well defined. Accuracy was seen to be similar in both the agents when it was seen. And that's it from my side. I think the learning never ends. I always tell to everyone, even my daughter, when she talks about that I have done completely 100%, I said, no, with a single breath, last breath of your life is your learning. And so learning never ends to you. And if mutual learnings, my email ID is there. So although you guys are experts, and it will be happy learning with both of us, mutual learning. So you can contact me at any times, and maybe I'll be also contacting you in the future if I will face any doubts. And thank you for your attention. Thank you everyone.
Yeah, thank you, Sweta. Thank you.
Now we are moving to the last session, MRI guided vacuum assisted breast biopsy. Demonstrator will be Dr. Palak, and moderator will be Dr. Shilpa. Lad ma'am.
You have to catch up, Palak, somewhere. Yeah, please go ahead now.
She is a consultant in breast imaging and interventions at NM Medical, Mumbai. She is subspecialty head in ICRI and IRI. She works in governing council member, Breast Imaging Society India, former consultant radiologist and assistant professor at Ottawa Hospital, University of Ottawa, Canada.
Yeah, who is presenting? Shilpa.
Okay, so the plan is I go through the steps of the procedure first, and then Palak will demonstrate the actual procedure. Okay, so MR-guided breast biopsy. Here's a case, biopsy proven invasive ductal carcinoma, 9 o'clock position of the left breast. Pre-op MRI was performed to assess extent of disease. MRI confirms unifocal left breast cancer. And voila. And the surgeon and the radiologist live in harmony ever after. But how many times does this happen? In real life, this is what we see. Yeah, like all these dots and ditzels, and we are wondering, oh my God, what is the real cancer? How do I find it? And how do I biopsy it? Okay, so this is what happens, and that's why MRI becomes challenging to do only because of this problem of specificity. So how do we work around it? Well, we find our best to try the lesion, but it can be a challenging task if we are using a second look ultrasound or we are using mammogram to find what we are seeing on MRI. So it's really, really hard. But nonetheless, in countries like ours, where financial constraints are real, we try our best to use a second look ultrasound to find these lesions so that we can do a biopsy. And how do we do that? We try to look for correlates. Is there fat fibroglandular tissue? Is there an index lesion from where I find it? Is there a cyst or a scar adjacent to it? So these are the correlates we try to go back, especially so in areas of non-mass enhancement. It can be particularly challenging when we try to do a second look ultrasound. Now, in a case such as this, we are trying to figure out whether, okay, there was a dilated duct here, there was fat there was fibroglandular tissue. And then with those correlates, because this area of non-mass enhancement is larger, we attempt to do a ultrasound-guided vacuum-assisted biopsy. And in this case, we got lucky, and this was in keeping with DCIS. But this does not happen all the time. Okay, why? Because no ultrasound correlate identified can happen in an average of 45% of the times, which means the lesion is there. I'm not seeing a second look ultrasound correlate. Then how do I biopsy it, and should I biopsy? Is it important to biopsy? That is the first question. The answer to that question is yes. If the lesion has suspicious features, then, or indeterminate features, then for lesions with no second look ultrasound correlate, about 27% of the times, they can still be malignant or pre-malignant. And therefore it becomes mandatory that we prove or disprove it with a MR-guided breast biopsy, whether it's cancerous or not cancerous. So these are the techniques that we use for the setup. We first correlate for sure with second look ultrasound. We also try to look on the mammogram if we can find some microcalcifications corresponding to the areas of non-mass enhancement. Okay, but if there is none, then the decision is to go ahead with the MR-guided breast biopsy. So lesion visualization becomes important, visualization of the obturator, confirmation of accurate lesion targeting, post-procedure mammogram with marker clip. All these are important steps, and a radiology, pathology, concordance or discordance. So what do we do as far as the patient is concerned? We give some educational material ahead of time. We take informed consent ahead of time before the patient comes for the procedure. What are the things which are different in an MR biopsy kit as compared to what we saw so far with ultrasound biopsies? Okay, so some of the important things are here. There is a needle guide block, there is a trocar, then there is a cannula, and there is an obturator with gadolinium in it. Okay, so the ideal way of doing a MR-guided breast biopsy is vacuum-assisted procedure. Okay, and we have seen in the previous talks how this vacuum device is used. Okay. for a MR-guided breast biopsy, we literally use the same breast coil that is used for diagnosis and intervention. Grid gives just enough compression so that the breast is immobilized, but the compression cannot be too much because we are doing a contrast-enhanced MR and we want to make sure that the contrast also reaches the lesion. And dynamic contrast-enhanced MRI with a fiducial marker clip or a vitamin E capsule on the grid is what we do. Okay, so this is what the grid looks like, and we'll put a vitamin E capsule or fiducial marker right there. Okay, and what does the vitamin E capsule looks like? So this is what it looks like. So wherever you suspect that area of enhancement or non-mass enhancement, that's and we are trying to target. But right in the center, we put that vitamin E capsule of the grid, right in the center of the grid. So from there, we can calculate where we need to go in. For lesion visualization, we can see the lesion only until the contrast washes out. Therefore, this is one procedure where you want to plan properly. You know, you think twice, do all your planning based on your previous MRI, and then we have to act faster when we start the procedure. Okay, how do we do this? We give local anesthetic in the spot here. We usually use a combination of lidocaine with epi, and bupivacaine. There are some differences, as we saw through the talks, where people use different kind of local anesthetics, but this is the combination that we prefer. Okay, then when we do the procedure, how do we do it? The first part is we put the block guide along with the cannula and the trocar into the spot into the part of the grid where we have seen the lesion. Then we remove the trocar out and we replace that with this obturator. This obturator has in its tip the gadolinium there. Okay, and once that is done, and once we obtain some images, we are confident that it's in the right place, then we introduce the biopsy needle. Okay, now few things to remember about the tip of the biopsy needle. Okay, so the tip of the obturator, wherever it is typically in this spot of the aperture. So this is a biopsy needle, okay, after we have put in through the cannula. This is the spot where it will be obtaining the sample. So we have to understand that there is about 1.9 centimeters of dead space beyond. So the dead space is literally 9 millimeters, but there is about 1 centimeter beyond. So this is the spot where we'll be doing the sampling. Okay. Here's a case of linear non-mass enhancement. When we have done all the planning and we put a needle inside, after the procedure is done, we obtain another set of images, and on that set of images, we see a nice little cavity corresponding to the spot of the linear non-mass enhancement. This is how we know we have gotten the right spot. Okay. Do we obtain only one set of images? Typically, we obtain on sagittal as well as axial to make sure that the tip is in the right spot. What are the kind of lesions that we biopsy? Non-mass enhancement with no sonographic correlate, seen only on MRI, or we can also target in the retroareolar region can be a harder area to see on ultrasound, okay, because of the shadowing from the nipple areolar complex. The third type of lesion is smaller masses with no sonographic correlate. Every single time we have to make sure that we compare the pre-procedure MRI to the post-procedure MRI to know that there is a proper cavity in there and we have obtained enough amount of sample. We also leave a marker clip at that spot and obtain a post-procedure mammogram to make sure that we have targeted the right area. Okay. One point that I would like to emphasize here is vanishing lesions. It is a real thing because there is a lot of parenchymal enhancement, hormone-induced parenchymal enhancement. So, and we see it often in cases of high-risk lesions if it is not scheduled between day 7 to day 14 of the menstrual cycle. In this case, this was considered to be an area of non-mass enhancement. No sonographic correlate was identified. She was called for a MR-guided breast biopsy. On the day of the MR-guided breast biopsy, there was absolutely no enhancement seen on the early or the delayed post-contrast images. So we have to be aware of this fact that there will be hormone-induced enhancement in the breast, and this is called a vanishing target. In such cases, we can do a follow-up MRI. But follow-up MRI is a normal thing, and I will talk about that in a minute. Complications like all other vacuum biopsies are hemorrhage, hematoma. Infection practically never happens, but for hemorrhage at the time, good compression is all we need. Breast is a superficial organ, so in our experience, we have found that giving good compression for a good 10-15 minutes, like having literally a 10-pound pressure on the breast, helps to stop the bleeding. Okay. We also tell the patient when she goes home, she can do some ice compression. That also helps with the hematoma, hemorrhage, and bleeding, etc. It is pertinent that we do a radiology, pathology, concordance, or discordance, which means after the result arrives, we want to make sure that it, whatever we were suspecting, that is what is seen in the histopathology report. For example, you're very sure that you're suspecting a DCIS, and the histopathology report shows just normal breast tissue, then it is a discordant report. You need to act on it further. Okay, if it is benign, like if that non-mass enhancement shows fibrocystic change or sclerosing adenosis after you have done a vacuum-assisted biopsy obtaining 12 samples, then we consider it concordant. But nonetheless, to keep the patient in the safety net, we do a follow-up MRI typically in 6 months and then 12 months, okay? If there is increasing lesion, then we know we got to intervene and the patient does not fall through the safety net. And it's important, we face a lot of constraints in our practices in India, especially socioeconomic reasons play a big role. And therefore, from time to time, we will do problem solving with other techniques, other methods. But having said that, as far as possible, we try to do what is evidence-based. Every now and again, we will have to do problem solving maneuvers in the form of, say, localizations or something to that effect. But the reason why we want to stick to protocols is, as Mahatma Gandhi said, our future depends on what we do today. So on that note, I would like to stop right here and over to Palak.
Thank you so much, Dr. Shilpa. Can we have the video for the procedure? So a lot of nice points have already been covered, so we get directly to the part where we are doing a procedure. So this is a cradiocaudal run of the breast, and we are seeing 3 areas of non-mass enhancement, and this one looks the most prominent, the one that just went. So that was the target area. The other 2 were not as intensely enhancing. Next.
So what we do is we put a vitamin E capsule in the center and concentrically roll around or gauze piece around it.
Marker, but if you don't
This will
have
be
a
still
CC marker,
small.
this is the way
So we
we can
take the
place a
other
vitamin E
half of
capsule.
this.
Wrapping it concentrically gives it the bang center location within the grid, so the measurements are going to be more accurate. It replicates a CC marker.
So this makes a capsule to be lying in the center. And then this can be hooked, squeezed inside. This gives us a capsule fairly in the center of the grid. Otherwise, when it is slanting, it may not give accurate calibrations and save with the microtoner. So from the home page, I chose Dyna localization and we chose the breast protocol. And this is a standard home page with 4 view images that come on the screen. We first confirm that we have chosen a lateral grid, a 10-gauge needle biopsy, the type of biopsy needle that is going to be used, and the laterality of the breast. So we will choose the left breast. Now this is a sagittal image, and we go from the lateral to the medial aspect. So as we follow this arrow, we want to choose a lateral or an outer approach. So we keep coming out. This arrow tells me I'm towards the lateral skin. Now we continue outside until we first start seeing the CC marker, and this is the entire marker. We want to calibrate our distance from the skin surface. So the CC marker, which is touching the skin the most, we chose this point, and this is conventionally placed into the D4 slot in our institute as a protocol. So now we will just load the subtracted images. Usually the third subtracted image is where we start from to look at the early enhancement.
So these are the ultrafast sequences.
So we
where
did
have
see something that
acquisition
came,
within 60 seconds.
confirmed that we are in the upper mediastinal level. So this is the upper part of the breast. So there is usually a bit of a suboptimal resolution of the superior most and inferior most cuts and some wraparound that may be seen in an ultrafast sequence. So we must be aware of it before we start including whether we are on the upper or the lower side. Now, we did find something enhancing here, confirm it. So this is well enhancing. This is just below the level of the nipple, and this corresponds to our target area. Good. So I think it is very well seen on the third and the fourth subtracted sequence. So we will choose to send the fourth subtracted sequence now on the DynaCAD. So let us push this to PACS. So this is the subtracted fourth image, and this is being sent to DynaCAD. So now we have sent it to DynaCAD. We will check open. So we have the CC marker detection and the required sequences coming. So we start scrolling. We just saw something. And we will go back. This is on the upper side. We confirm we are going down towards the nipple, and then on the lower side we start seeing this, and we are okay. There is another one which is enhancing more. So we will come back and check both the areas well, and we will choose the early enhancing. So this was one, and the second one is much more fainter. So we have chosen to take this as a target lesion. Now, once I have chosen the target lesion, I would need to confirm the series and image, which is hidden over here for the sake of confidentiality. So this is image 73. Let me go a little below, above, and it is best seen over here. So either 72 or 73. So this matches with the section that we've chosen at slide 72. So I think we are good to go. We have a match. So we are at 72, we come back over here. So this is a central target area. We double click, and this is a lesion which is automatically calibrated by the system for an ideal approach. So what we see here is we need to always confirm the position of the patient, and because the image flips in this planning sequence later after the final lesion assessment. Until then, the superior and the inferior surface is always a flip depending on lateral or medial approach. Hence, before going in, it is always good to confirm the position and the lie of the patient. So this is going to be the left breast if the head is here, and this will be the lateral approach. So now confirming and replicating this grid over here, that is how it is. So our conventional image will be D4, where the target localizer is, and this will be D4. So now we again confirm that we need to go a bit superiorly, that is towards the chest wall, and caudally towards the foot. So we are going to go one above and one on the inferior aspect of the patient, and within this block, this is the ideal position that we need to enter inside. Furthermore, we have an automatic calibration because of the software. So let us look at the measurements here. The stopper set is automatically suggested to be at about 6.5 centimeters. So we confirm this is 6.3 centimeters. This is the obturator which is shown to be coming out, and this tells us that the calibration is such that the tip of the visualized obturator will be at the 0 level, and the centimeter calibration is done from here. We need to understand that about 2 centimeters of this is going to be remaining outside the skin within the MRI grid, whereas it is approximately 4.3 centimeters which will go from the skin surface. I can just once cross-check to see what is the approximate distance from the skin surface to the center of the point, and that is about exactly 4.3 centimeters. So we have a match with our manual calibration as well as the auto calibration by the software. And now our point takers to go, when we go inside the MRI room, are the localizer, where it is, which slot we take. This is in the inner aspect, and the depths that we need to go in. The information is also relayed over here. It tells us which block, which needle we have chosen, the stopper set, and the offset. And offset means that the central point that we have chosen is 0.5 millimeters away from the center point of the needle that will be targeting. So just imagine the center will be actually a little towards the head end over here, but there is an offset of 0.5 millimeters. So we have a replicate of this. We keep a laminated sheet, so I know that where I need to be along the antero-inferior part. This is the approximate hole of my entry, so that there is no error or no scope of forgetting by the time I go inside the MRI room. So I have to go in 6.3 centimeters. So first thing, the dimensions. I will rotate. The stopper is always a little on the tighter side because it has to give a good grip eventually. And upon it tight against the pressure of the breast. So this is 6 centimeters and 6.3 centimeters. So once my stopper is placed, I will have to introduce my trocar into the cannula, and we choose to let it be just a little outside. Now choosing the ideal entry point. So we have chosen the lower part, lower inner I would say, towards the center, but not exactly the center. So we go in from here and we tighten this up. Once we screw it, it is tight enough, so it is going to maintain its grip, and we will enter through the trocar. So now when I'm inside, since we cannot take an image once you're in the MRI read, so this, if this is the grid in the lateral position, 1, 2, 3, 4, D4 is where the fiduciary was or the CC marker was. I will 1 towards the chest wall, 1 inferiorly, and I will be going inside in this position, and I will fix this. Once this is fixed in the position that I want, the trocar will then be pushed inside. We push it in gradually so that the distance is a straight line and it does not deviate in an angulation. Once a trocar has gone inside, it is removed carefully. At every point, we hold the cannula so that the cannula, if it is loose fitting or if the stopper loses its grip at any point of time, it is not going to slide out. And then we replace with the obturator. The obturator, this is a Vizilab obturator, filled with a MRI compatible MRI detecting contrast agent. And the tip that we saw is this line, just a little below the tip. This is where the zero marking begins. And the zero marking is which marks the center of the target. So this is a medial and the zanza. It needs to go into the groove on both sides. And then it has to be click inside. Then it says sample for calibration. So we press the notch. So once the calibration is done, we know that the system is ready to use. However, by protocol, we always check the vacuum function as well before going on with the biopsy. Right. So now we will take local anesthesia. Now one thing that we always keep handy is, now in this patient we have to go in 6.3 centimeters. Hence, the depth penetration is not going to be sufficient with a usual needle. And for that reason, it is always helpful to pre-plan and always have a spinal needle available so that whenever an axis is changed or an approach is changed, we have the depth penetration covered. So here I will give local with a spinal needle. Another thing that we always keep handy is have a sterile plastic scale which goes and it remains in the sterilized disposable kit, so that if at all we have some assessment of the depth to be penetrated, we know. So this is going to be, I need to go at a distance of around 8.5 centimeters from this end. So this will be about 6.5 centimeters. So I know visually I need to be about 1 inch outside the surface of the MRI grid so that I give adequate local anesthesia. This is important for patient to be comfortable when the procedure is happening. So earlier we used to have a small scalpel without a handle, and we used to have a protocol of wounding it, and once it is transferred to another person's hand, we give a loud verbal command help so that there is no chance of slippage. But having a long handle which is compatible with MRI, it's a plastic handle, is helpful because a deep, bold incision needs to be taken to avoid the slow plowing effect.
This is just to show the prone position, and one pointer is the patients get very uncomfortable, so it's good to have good supports by their
And so we are
arms so
going
that
from the
they're
bottom to
comfortable
the
during
top, and
procedure.
okay. So this is where we are at 73. This is a target lesion. We are quite away, and that is because there was a significant slow plowing effect, and it was very difficult to introduce. So this lesion is here. So the subtracted and the non-subtracted needs to be compared to make sure that this is the lesion, because the resolution changes in the non-subtract targeting sequences. So from here, we will calibrate. We need to go in about 1.5 centimeters further inside.
So this again, contrary to stereotactic VAB, it's just more like a robotic biopsy. So it rotates on its own and you do not have a hold on it. But like ultrasound, MRI also has
So start
flexibility.
coming up
So we can
from the
have
inferior
targeted
position.
codes.
You try to find the lesion. Going superiorly, it is just about started to see, and this is a needle entry. Coming further superiorly, it is matching at the level that we wanted, confirming sequence 71 by 71 series. Coming superiorly further, 1-1 cut. This is the central axis of the needle, coming superiorly, and 1. So this is also targeted, and this is covered by hematoma. So there is a radicular targeting.
So just that one thing is that in MRI we can choose only one sector. So when there is an offset of, sometimes the offset can be about 2 millimeters. So in that situation we target where is our offset in what direction, and we take additional cuts just from that same axis, multiple about 6 to 12 of them before we take the random 360 degrees circulatory cuts.
Okay. So in this case, had we left the marker clip?
Yes, we always put a marker clip and we do a check mammogram as well to confirm the location of the clip.
Yeah. Do you come across situations where you may feel that the marker clip has got displaced more because in MR sometimes we'll end up taking more number of samples, say like 12 for a smaller lesion, and how do you deal with that?
Right, so a marker clip is placed, but we have our images taken before. And even if I have a marker clip which is not displaced, it is going to be very difficult because a mammographic positioning and an MRI positioning itself is completely different. So if I have something shown about in the superior aspect, where my true lesion was in the superior aspect on the MR, it might be in the central lesion on the mammo. So with or without displacement, that match is always difficult. So if there is it goes with the understanding that the clip marker may not be precisely accurate, and if there is a need to go in, a wider resection may be needed.
Okay. And do you, after the RAD path or at any point, do you have a follow-up MRI?
Yes.
Only if there is a RAD path discordance?
So we would call a RAD path discordance if it is a 4C or a 5 reported, then we might want to re-intervene rather than put it on surveillance. But if it is like a 4B and we are worried about it, it is negative, well targeted, we would still ask our patients to be on a closer follow-up with an MR until the stability period is achieved, and then the patients can be off the follow-up.
Okay. Other than a vanishing target, what are the situations where you have not been able to do a MR-guided breast biopsy for a lesion for which there is no sonographic or mammographic correlate?
Right. The 2 pointers, I mean, even the retroareal lesion that you showed, so if you do have an access for a retroareolar where you have a sufficient, the transverse diameter needs to be there enough to cover your needle. If that is taken care of, then we can take the targeted cuts posteriorly. So place the needle a little more anteriorly and take posterior directed cuts is one option. But very often it's a conical area. We may not have the depth. So that is one area. And the other is medially placed lesions very close to the chest wall. So there is a limitation of access from the medial side. Outer side, the patient can be placed in an oblique position and still target, but medial, there is no entry. So then a hook wire localization is a last resort.
Right, thank you. So any questions from the audience? Well, nice. Thank you, Palak. That was a very nice demonstration.
Yeah, thank you.
So
Thank
much.
you, Shilpa. Thank you, Palak.
Thank you, sir.
Where is Dr. Kajri? Dr. Kajri, please.
Thank you, sir. Thank you, the chairpersons. Thank the delegates and the wonderful faculty for this interactive as well as great session. So this is the QR code for the e-book of the breast booklet which has been released today, and it is freely available. It will be displayed in between all the sessions, and I request all the delegates to scan this QR code to get your free booklet. So with this, we conclude this session, and we'll start with the next session, and I invite Dr. Palak for the same. Thank you.